Okay, we'd now like to welcome a dual presentation from Associate Professor Rebecca Mitchell and Dr. Roger Harris. Associate Professor Mitchell is an injury epidemiologist at the Australian Institute of Health Innovation at Macquarie University in Sydney, and a valued member of the ANZ Hip Fracture Registry Steering Group. She also chairs the Data Management and Subcommittee. Dr. Roger Harris is a geriatrician from Auckland in New Zealand, and he was a clinical lead for the New Zealand arm of the registry from 2012 until 2017, and he remains the co-chair of the New Zealand Governance Committee, which is a member of the overall steering group. He continues to lead work in implementing the FFN registry, and we'll hear about that more later today. Welcome Rebecca and Roger to speak about bone protection medication in sprint audit.
Thanks, Catherine. So just in terms of conflicts of interest, I've just put up where we've received funding or support from a number of research grants funding salaries. So in terms of osteoporosis, around 1 in 5 and 1 in 3 females aged 50 years and over have been estimated to have osteoporosis in their lifetime. And as we know, osteoporotic fractures are common among older adults, particularly hip fracture, with around 13,000 hip fractures in Australia and 4,000 hip fractures in New Zealand each year. And as we know, low-level falls are one of the most common causes of hip fracture and leading to adverse impact on an individual's health and well-being and their quality of life. And so early treatment of osteoporosis is recommended, and there is evidence to support from systematic reviews and meta-analyses of using bone protection medication after hip fracture. And you can see here from 26 randomised controlled trials and 46 randomised controlled trials, there is evidence of reduction in secondary fracture rates by at least 50% with taking bone protection medication. And as we've heard, good practice can be driven by implementation of clinical care standards. And in Australia and New Zealand, we have the 6 quality statements in our care standard. And we're just going to be looking at quality statement 6, minimising the risk of another fracture. So all hospitals in our Australian New Zealand Hip Fracture Registry do report on quality indicator 6A, looking at the proportion of patients with a hip fracture who receive bone protection medication prior to discharge from hospital. So this is how we're doing. This is some results from the Australian New Zealand Hip Fracture Registry. This is just Australia at this stage. You're looking at focusing in on the navy blue line. So this is who's received bone protection medication on discharge. The top 5 rows are the average for Australia for the last 5 years. And then underneath we have, this is half the Australian hospitals. And you do see we do have some good performers up the top there with over 70% bone protection medication. Here's the other half of Australia, so you can kind of see it does taper off a bit. If you are interested to see where your hospital is performing, all our Australian New Zealand Hip Fracture Registry reports are available for download on the Australian New Zealand Hip Fracture Registry website. And in terms of New Zealand, they're doing a bit better, so at least over 30% on average have bone protection medication on discharge. But again, in New Zealand, they have some really good performers, over 70% and 60%. But how do we do compared to others? So England and Wales, around 52%, so they're doing better than we are, of patients have been prescribed bone protection medication at discharge. In their 2020 UK Hip Fracture Registry annual report, around 45% of patients had been prescribed bone protection medication. So I think in Australia and New Zealand we can do a bit better. Although there is issues around adherence to medication over time, and you can see here that a couple of studies have shown that adherence does wane over time, but there has been higher compliance rates with using intravenous treatment compared to oral. So what we did in Australia and New Zealand, we're quite interested now in, well, if people aren't being prescribed bone protection medication at discharge, who's not being prescribed? And so with our registry now, we looked at the last 5 years of patients in our registry. So we had over 55,000 hip fracture patients. And we looked at the characteristics of those who were less likely to be taking bone protection medication. And you can kind of see they fall into two extremes. So people who are younger and healthier were less likely to be taking bone protection medication. And then at the other extreme, you have people who lived in residential aged care facilities, who had impaired cognition or delirium identified, or who hadn't had a specialist fall assessment conducted. So kind of at the other extreme, where you're looking at, I'm guessing, more frail and cognitively impaired individuals. And so then what we thought we'd do is, well, let's run a bone protection sprint to get some further information about what are some of the reasons why people aren't prescribing bone protection medication. We did look at some of the generalisability. So we ran the sprint, but we did look at some of the generalisability between some of the key variables that we collect in the registry and that we also collected in the hip fracture audit. So for key demographics, age and gender, place of residence, ASA grade, we did have good generalisability between our registry and the audit, but there are a couple of characteristics, as you can see there, where we didn't have good generalisability. And then I'll hand over to Roger to go through the audit and some of our results and conclusions.
So we did a sprint for a month. So this is just data collecting, and people volunteer their site to collect data. So we're just doing the direct bone active medications. We're not doing vitamin D. You can see Australia's got 18 facilities, New Zealand's only 8, and we've got a small number of patients in New Zealand, and I think that's, we've got a Hawthorne effect, and I think the New Zealand ones are showing better than what the other data suggests. There's quite interesting differences. In Australia, most of the forms were completed when people were still in orthopaedics, where in New Zealand it's mostly when they're in the rehab unit. Now, the really interesting story here is the difference in the vitamin D. New Zealand does not do vitamin D tests. What happened in the reforms in the 90s, there was incredible financial restraint. The boss of clinical biochemistry at Auckland Hospital thought the quality of his test was, could be better. He thought that's also a very expensive test, and for that amount of money, the cost of the test, you could replace vitamin D for several years. So with a lot of negotiation, they decided that they would no longer do vitamin D, and everybody who wasn't already on vitamin D would just get replacement. So you can see that's what those numbers reflect. And initially it was 300,000, i.e. 650,000 tablets, but that's been revised lately to 2. So if you're not on vitamin D when you come in with your hip fracture, you will get 2 tablets and then be given your treatment if somebody gets around to doing it. Now, the simplest way of thinking about this is that the main reason it's not done is because it's completely overlooked. There's no other way of getting around it. It's as simple as that. And I know I shouldn't go straight into what's the cure for this, but Min Yi, who works at North Shore as a geriatrician, just works in orthopaedics, and a lot of her patients go across to the geriatricians for rehab, and she checks on them and says to them, "How are you doing with your bone meds?" And they say, "We're doing great." And she says, "No, you're not. I've checked." And I think really it's just a lack of real-time feedback about what's going on. And So anyway, that's my solution, and that's way ahead and a bit out of court at the moment. So at the bottom there, you can see some people they've already had it, and what they get. Okay, we'll skip that to the next slide. So this is the reasons for not giving it. And in Australia, the big thing is we're messing around with vitamin D. In New Zealand, because we're not doing that, we run into problems with renal function. And that's because the sort of national plan, if you like, is to replace the vitamin D and then give IV bisledronate while they're in hospital. But if they've got poor renal function, you can't do that. The other thing is in New Zealand, we don't have access to denosumab, but you have to fracture on a bisphosphonate before you can get the denosumab, so we can't use that. You can see there's a frailty thing there, but that's all small beer. So the big thing is, it's overlooked. The second thing is, it's vitamin D in Australia and renal function in New Zealand. Now, around about half in their discharge summary have an ongoing plan for bone health. And is the GP requested to talk to the patient about their bones? Australia does a lot better than New Zealand. It's pretty bad. So it just signifies once again this sort of thing is not top priority for people. Sort of understandable, you know, you get this complex patient, you do family meetings, you meet all these problems, and bones just get left off the list. So here's some of our limitations. You can read that quicker than I can say it, but I think the sample size, particularly for New Zealand, is too small. So there's consensus that basically people should get treatment sooner rather than later, because your highest risk of getting another fracture is sooner. And what else we got there? And in New Zealand, we're trying to do the parenteral medications because you get better adherence rather than with the oral. So this is for aged residential care, which is pretty much the same. It's just that you need to think more carefully about renal function and the risk benefits. The other thing that came out of this thing, just to talk about vitamin D again, is vitamin D is evidence-based to prevent falls for people in residential care. In both countries, it's about 50%, so we can certainly do better there as well. So we're not doing very well with the bone protection medication. I would think that everybody should review their processes to see what's going on and whether they can remind themselves to do it. In New Zealand, we've got fracture liaison services coming in nationwide, so hopefully that'll assist. Australia's got some. I think New South Wales is quite well off for FLSs, but it's a bit more patchy. And we've got a few acknowledgements, and that's that.
Thanks very much, Rebecca and Roger. And certainly, that, you know, the sprint audits have been a very exciting development for our ANZ hip fracture registry in the last couple of years.